So let's talk about genetic testing. The NCCN, the American Society of Clinical Oncology, and the Society of Gynecologic Oncology recommends that all patients with epithelial ovarian cancer be tested for germline BRCA mutations. Would we agree with that?
Absolutely.
I think, Brad, we all do this and follow the guidelines.
I love it. Thank you. So who should counsel those patients? I think you'd also agree that those patients need genetic counseling. Katie, do you refer those patients to genetic counseling, or would your nurse practitioner, would you counsel the patient?
In our practice, we do have genetic counselors available, but not enough. And so I counsel the patients myself for genetic testing, and we'll talk, I think, a little bit more about the type of testing one would send. But I counsel them, and if we have a positive result, or if we have sort of a non-informative result in a patient whose family history is striking, you know, those are the patients that I'm going to prioritize getting into the genetic counselors, just because you just can't send every single patient. There's not enough genetic counselors. I think the best practice is to send every patient who needs testing to a genetic counselor 100%. They do a better job, but there's just not enough of them, so I counsel my own.
And I see everyone nodding their heads, so I'm not going to discuss that further because I think that's fairly common. And in my practice, my nurse practitioners really enjoy that, and they've taken that as their passion. And because, as you said, Leslie, right, that it's the cure of ovarian cancer. It's the Angelina Jolie effect, identifying patients at risk, stopping it within the kindred by doing a risk-reducing surgery. Are there other reasons to test for BRCA other than risk-reducing surgery? And if there are, what are they?
Prognosis. They have a different prognosis. Also,
tell me more. What kind of prognosis?
So
better or worse?
In general, they have a better prognosis than those who don't have germline mutations. In general, it's not always the case. Also, to triage them to clinical trials, and in the frontline setting, you know, it may be that we start to triage them to treatment based on their germline BRCA status. It's not currently the situation, but that's evolving.
So Oliver, is it just BRCA, or do they need testing for what we call panel testing, meaning other genes that may be associated with ovarian cancer? And you're nodding your head, so tell me.
Yes, I think absolutely. I mean, the panels of genes that increase a woman's risk to develop ovarian cancer during a lifetime is constantly increasing. The genetic mutations we're identifying, though, are responsible for a lesser and lesser percentage of those ovarian cancer cases. And nevertheless, it's very important to do these panels. And as a matter of fact, I was curious what you guys do, because a woman that comes to my clinic and had germline mutation 5 years ago had a very different, smaller panel than is available at this point.
So in my practice, we have kind of created a threshold of 3 years, but that's unstable. When do you retest, Leslie? In other words, when does someone show up and say, look, I've been BRCA tested, maybe even a panel? When is that no longer valid because the science has moved on?
Oh, I don't know. I don't have the answer to that question. I'd be interested.
But yeah, we've talked about it as our group.
Because patients ask me,
right?
And it's hard.
We say so. We say about 2015. What do you think, guys?
For just BRCA?
Well, no, let's say they had the panel at the time.
Yeah. Yeah, I don't know. I was going to guess 5 years or so.
Okay.
So.
I don't know that there's a set time. I think that the companies that are doing the genetic testing have been pretty informative when the panels change.
Right.
And so it's not a common occurrence, but we have patients who, I'm taking care of a woman whose mother unfortunately died of ovarian cancer in our practice 10 years ago and was tested and was negative. So she's definitely getting tested, A, because she needs it, but she was tested at the time her mom was also negative, but she's getting retested now because the panel's completely different.
Yes. So the BRCA testing is different and the panel
is different. There wasn't a panel then, and
right.
the genes, the mutations that you test for the BRCA gene have changed. So I think in those circumstances, that might be another patient that I would send preferentially to the genetic counselors to sort of guide whether or not we retest.
So it sounds like a risk-based approach, which I think makes a lot of sense.
Yeah.
So we all agree, and I'm going to say it again, every patient, which means every patient with ovarian, fallopian tube, and tubal cancer should be tested for germline BRCA mutation, and ideally tested for a panel, and that counseling is mandatory, and who does the counseling is open to your practice pattern. Now, BRCA can also happen in the tumor, but not in the germline. That's obviously called a somatic mutation. What is the role of somatic BRCA testing in your practice, Katie?
Currently in our practice, outside of clinical trials, we're testing patients at the time of, so ovarian cancer patients at the time of a recurrence for somatic mutations, and we typically, depending on the length of time from their primary surgery, are re-biopsying them, although maybe we don't need to be doing that. Because you are going to have some patients who are cured and you don't ever need to know that information. So we do wait, and again, the panels change, so we want to get the most up-to-date panel when we need the information.
And the tumor may evolve, right?
And the tumor may evolve.
Heterogeneity.
Right. How much that happens, I think current studies are investigating that, are really going to inform the necessity of repeat biopsying in ovarian cancer. We don't know right now.
Tom, do you test for somatic up front?
We do. We send a panel, so we get that information.
Interesting. So Katie says, oh, I'm going to re-biopsy the tumor because the tumor may change. We're all familiar with the cell-free DNA technology. Is that something, is that an opportunity? And the beauty of cell-free DNA, right, because you have chronologic heterogeneity, but you have spatial heterogeneity. And if you do the cell-free DNA or circulating tumor cell, but cell-free DNA, it's the entire tumor that has been interrogated. What do you think?
Maybe. But I think that would be beautiful.
You're the expert. Don't tell me maybe.
It's a beautiful theory, but we don't know this. I think we have evolving data with a beautiful paper out of Vancouver in March of 2018 that looked at the intra-patient heterogeneity of ovarian cancer metastatic site. And I think that paper in 38 patients with 250 biopsies really brought home the point that these sites are very different when it comes to the immunological profile, but also likely to the genomic profile. And I think we have to still do correlative studies on how cell-free DNA is representative of at least most of the tumor site inside the patient. That's at least my opinion.
The other role, Leslie, for cell-free DNA is prognosis. So we live in a CA-125 world. Patients who are treated, we monitor them with physical exam symptoms, CA-125. Some people say, I'm going to see if the cell-free DNA comes back. Mm-hmm. Does that make any sense, or we don't really, that's not added value in more carefully monitoring the patient for recurrence?
That's been shown to be of value in prostate, correlative, actually better correlative than a PSA level. So we haven't.
But in ovary, should we do it?
We have not looked at that yet.
Okay.